Thank you, everyone. That was just an absolutely wonderful set of lightning talks to help us get this day started. I'll be moderating our discussion session for the next 30 minutes or so that we have on the clock. And I wanted to start with an overarching question that I think many of you can answer. And just a reflection on the language I think that Gwen and Shanita both used about trust, and the electronic health record as a vehicle for trust in a system that is often difficult to penetrate by patients and their families. When I think back on, when Larry and Neil and I were all trained, and we all learned about something called problem-oriented documentation. That was really the way in which it was a brand new way of doing documentation. Larry Weed invented it. It was actually thought of as one of the first innovations in electronic health records, even though it was on paper. And we've all been trained in this form of clinical documentation. And the documentation has served many, many purposes for ourselves, to remind ourselves how we're managing the patient, to communicate with other healthcare providers who are also taking care of our patients. And it leverages a very complex set of clinical terminology that was never intended to be accessed by the patient or accessible to the patient. And now we have our patients who, with the Open Notes initiatives, are now reading all of our records. And many institutions I've seen have actually put in a disclaimer on their notes saying, this is written for, by doctors, for doctors. It's not meant for patient consumption, but here you go, you have it. Just be aware that the language we use may not be the language that you're expecting. And I would say the same actually for the pathology reports and the radiology reports, which I'm constantly having to interpret for patients who are reading every single line and Googling every single term to try to understand the clinical significance of something that seems really scary to them that may actually just be an incidental finding, right? Or a technical piece of the pie. So all of this to say is my question to the panel is are we at the tipping point? Are we at a precipice where we need to really start thinking about a dramatic change in the way we perform clinical documentation, understanding that our audience has changed, that our audience is not just a clinical audience, but our audience is also the patients and their family members or care team members who want to be informed, who want that information. So I'll start maybe with Gwen and Shanita, and then hear Dr. Schulman and Dr. Maripol's thoughts.
Yeah, I mean, I think absolutely. And I think, in my 25 years, I guess, of advocacy, one of the, there have been a number of themes, but one of the themes has always been, whose medical record is it? And who does it belong to? And it is, and why was it never shared with patients? Why did patients and families and communities have to really advocate for access to information about ourselves? So I would say absolutely. I would say it is our record, and it should be written in a way that we are thinking about how we co-plan and co-create our healthcare plans, and not just from the perspective of how the physician or the healthcare provider is treating us, but how we are making how we're doing this together, and have responsibilities to each other. The responsibility doesn't just go one way. From the trusting relationship goes both ways. It's not just from patient to physician or physician to patient.
I would agree. This is Shanita. I would agree with that. I think that this is a really critical time because as patients have greater access to the electronic health record, and it's being used for different purposes now, I do think there is a need to reimagine how information is documented. And I would love to hear from the active providers on the panel and who's in attendance today about what would be and also because I think this is an opportunity for patients and providers to work together to develop a process and a system that would be the best at serving both the needs of both types of groups. So patients need to know and be able to read and understand what's happening with their care. But, there may be advantages to the current, the problem-oriented documentation that, that patients may not understand, or we don't really quite know because it was created, it's been in service for a number of years. But I guess my question for, again, for the providers on the call is, I think from a patient perspective, it's really not particularly helpful, because if you read something or see a lab value, and you don't understand what that lab value means, or you can't put it into context, and it's sort of like, well, what are we expecting patients to be able to really do with the information? And I'm not suggesting that the solution is to restrict or eliminate access, but I think there has to be more done to the electronic health record to put it into context so that it is understandable and it doesn't, doesn't cause anxiety or cause, problems, on either side. So, and I guess, Mia, your talk really brought this home, is that the electronic health record was created for a completely different purpose than how it's being used now. And maybe it was a good starting point, but I do think we're at a point we have to think about, well, what is the purpose now for the electronic health record?
So, this is Larry. I would make a couple of comments. I think if you forget about the EHR for a minute, one would hope that the care is a joint effort, if you will, between the clinician and the patient. And that should be the basis of the care, stronger than components of it, which is like the EHR or other aspects of it. Most things in life, there's a trade-off. Sharing all this information, as Shanita mentioned, can be very confusing. Sometimes it's out of context. Sometimes it's a value that a patient might not understand. And we need to work to figure out how best to have that bidirectional communication happen. The other thing I think you have to remember is, everybody has their own view of the world. The radiologist who's looking at a CT scan, that's what they've got. They've never met the patient. They don't know the patient's overall context maybe as well as the clinician does. And they're looking at a set of x-rays and trying to interpret them. And that's one aspect that may not be in the total, really, context of the patient and the patient's care. So we still, that individual communication, as Gwen so, importantly highlighted, there's no substitute for that. And I think the context of sharing information really needs to be taken with that in mind. And, I'm not sure I have the solution to that, other than good relationships between the clinician and the patient that help, to make it work as well as possible.
Yeah, the only thing I would add here is I was reflecting on this question and remembering when our first patient portal was activated. And there was a lot of discussion at the level of the medical staff around what information should be released, when should it be released, what if a patient gets information before the physician had a chance to discuss it with them. The bottom line was that everybody agreed that allowing patients to receive the information in their chart was going to be great ultimately for communication between doctors and patients, because you don't want any secrets in between you in this relationship. And one of the challenges and questions, and I think it continues to evolve, is how you maintain efficiency in practice, or optimize efficiency in practice, so that something you've documented doesn't doesn't stimulate 500 additional follow-up questions that you could have, headed off by having certain conversations earlier on. So I think overall it improves communication and forces conversations about details that, frankly, the providers might not have realized were so important.
I think I'll just add that, with meaningful use and the requirement for the after visit summary, that may be an opportunity for us to provide more patient-specific language. But in doing so, it again adds to the administrative burden or the documentation burden on clinicians to basically create a note that's specific to their clinical world and the language that they need for documenting the medical condition of the patient, and then being able to having to translate that yet again. And I would say that at this point, it's really not part of any medical school curriculum to do this. It's not part of any training program. If we are really going to address this issue, we need to train our workforce and really start thinking about how we can minimize the burden of documentation while still achieving some of these goals. So that was just my last few thoughts on that particular topic. And let me get to some of the questions that we've had from the folks who are watching. This is one again that can be addressed by many of the folks, but perhaps Dr. Schulman, will start with you. This is a question from Dr. Amy Tverwick at the Mayo Clinic, who's asking about some of the issues you raised and the challenges that you raised. Are they really with the electronic health record, or are they with the way we're choosing to practice today? And should we be looking at changing the way we're practicing, since EHRs are essentially drive our workflow to a great extent? And then she had a few additional sort of refinements on that question. How do we balance between the patient, other clinicians, the increased need for structured data capture, and the payer and the billing requirements? I know that you can't possibly address all of that in one question, but I think it essentially gets down to the fact of that we are trying to force the EHR to work with our workflows, and now the EHR is forcing us to change our workflows. And do we need to be thinking differently about our workflows if that's the case?
So that's a really, really good point. And actually, I would say that it's a key point in that our workflow, our processes, how we work in clinic, how we work before and after clinic, getting ready for clinic, and how the EHR works need to go in the same direction. You can't ideally do one without the other. You can't decide on a workflow that doesn't work with the EHR. And the EHR should work with the workflow that has to happen when you physically go to clinic and see a patient in clinic. And we don't have time to get into the details of that, but many of us have looked into this. And frankly, we've not done a great job over the years trying to link processes and EHR function. I think we can do a lot better. And what I was trying to show and what we've done at Penn is we actually had a group of process improvement people who shadowed some of our oncologists in clinic to see what it was they needed to do to care for the patients, and what parts of that were related to the EHR and how they interacted with really physically what we did moment to moment in clinic. And it was a pretty eye-opening experience because they're not well connected. They're pretty disjointed. So I think we have a lot of room to improve there. But it takes the EHR vendors, frankly, to think about that more than they've thought about it in the past. And I do think we have opportunities to improve.
So I think the EHR needs a problem list. So I was thinking back to Larry's, one of his original, when he was quoting Atul Gawande, who said, this tool was supposed to help me master, and instead it's mastering me. And we just have to remember, the EHR is a tool. It is not, it should not have mastery over the relationships or over the processes. And it seems, how do we get away from the tools mastering the clinicians, the patients, everybody who interacts in the clinical system? I think that is one of the challenges.
Well, I don't disagree. It is, it's interesting. Several years ago in my institution at Vanderbilt, when we implemented our Epic electronic health record, everything really came down to that it is a tool that we make decisions about how we integrate it into our workflow and what is our workflow at our institution and how do we want that tool to help facilitate our workflow and drive that workflow. But unfortunately, sometimes it feels like the other way around. And then we get into these workflows that are assumptions that we make when we're designing a system that end up creating a huge amount of burden on top of it. So it's people, process, and technology. The EHR in isolation isn't the problem alone. I'm going to pivot for a moment to some questions that were being asked for Dr. Shanita Hughes Halbert. This one is a little bit more of a very detailed follow-up question from Randy Keidner at Astro, asking if the USC initiative utilizes the work from the Gravity HL7 Fire Accelerator.
No.
No, it does not. Okay, excellent.
No.
And then an additional request from Deb Levy at OHSU. Can you suggest any references for clinicians that they could use at the bedside to integrate language to address equity issues in documentation? And maybe
Sure.
Put some in the chat if you have any.
Sure, I'm happy to do that. I mean, I will say that this is an evolving field, and I think our work was among the first to really examine the question of the extent to which issues related to social determinants of health are documented in the electronic health record. So I'm happy to share with you our citations. We have a series of papers that have examined this issue. And I think where we are now is that there is sort of the Z codes that are being suggested for social determinants sort of, I think, have really broad buckets of categories for saying, yes, this patient has food insecurity. Yes, this patient has financial hardship. Our approach was to develop our algorithm based on validated instruments that from which patients would self-report their level of social isolation or financial strain or food insecurity. So our goal was to bring sort of apply an informatician approach, an NLP approach to sort of this patient self-reported strategy. And I think that's, in my opinion, that's where the documentation process needs to go. So it's not sort of this, certainly reflecting what the patient actually says, but the provider, I think, has a filter in which they hear things, they interpret things, and it may or may not be documented word for word from what the patient has shared or disclosed during the visit. So I'm happy to share with you our citations and the ones that informed our work.
Thank you so much. We appreciate that.
I would add one comment here. We may never get to a world in which every clinician documents key aspects of social determinants of health in the medical record. However, this is an area where linkage with data sources outside the EHR, such as block level data that can create a composite variable to express the social determinants of health for an individual patient based on where they live. And we've developed this, adapted other constructs for research purposes to integrate evidence from sources other than the electronic health record to unlock other types of research questions that otherwise couldn't be answered. and developing a variable for social determinants of health is one of those key areas.
I thank you for reminding us of that, because I do think that is, that certainly has been our approach as well. I will offer a concern, I think, with that approach, and that, area level measures, I think, are really important, but they they may not reflect sort of the person's lived experience within that area. And I think that's so important just to keep in mind, because one of the things that one of the reasons I became interested in ethical and social justice issues around using area level measures is, there's now the ability to take information from like Google Maps and get a picture of someone's home and then kind of upload it, integrate it into, or link it to the electronic health record. And I think that's really, innovative and could be very important. But I also think that, it could perhaps go beyond the level that a patient may want to share with their provider about their particular housing situation, and the specific aspects of their community. So I think we have to kind of be very careful in what we're able to, what information is sort of documented in the electronic health record about general sort of community level or social environmental issues, because they may or may not reflect someone's actual lived experience. I think it gives another dimension that needs to be acknowledged and recognized, particularly in cases where it's not possible, as you accurately point out, to document sort of individual levels of social determinants.
And I think if I could just add one more thing to Shanita's comment, we've done a lot of work around conversations about cost of care, financial toxicity, screening for financial and social needs, which is a very fraught and very nuanced issue. But when we had a panel talking about conversations about cost of care, and it was striking how many of the patient advocates and patients on the panel so that they didn't want to share. Some of them didn't even want to share their address with their healthcare providers. There were ways that people were profiled based on where they lived. There were ways that there were issues of personal money, personal finance that they didn't want to discuss. And so much of that had to do with trusting relationships and how the patient experienced the healthcare providers and health systems trusting them and making and sort of profiling and patterning them, and what that meant if they revealed some of this information. So it's really it's very complex. It's not just put in check boxes of questions. It's what do those questions mean, and what do they mean to people's lived experience? What do they mean to people's experience with the healthcare system once they have disclosed some of the information that could that people fear would prevent them from equitable healthcare?
I think what this conversation is pointing out is how complex the relationships between clinicians, the EHR, and the patient is. The triangle that Gwen mentioned during her talk, and clearly it's not a one size fits all, and we need to create infrastructure, including EHR, that supports the customization, if you will, or personalization of how we interact. None of us in this call are all the same, and none of my patients are all the same. And that's part of a clinician's job, is to understand their patients' goals and parameters for interaction and so on. Currently, the EHR doesn't give us many options in that regard, right? It just does what it's told to do, which is to release everything. We do our best to accommodate patients' individual needs and requests, but it's tough, and it's never going to be cookie cutter. And I think we just need to remember that.
You know, your comment on the customization is also one of the challenges I think that we face. One of the questions in the chat was in regard to with so many different EHRs out there, and with each institution implementing their own custom workflow of that EHR, how are we ever going to get to understand what best practices really look like? And how can we then disseminate those more broadly? The question suggested that perhaps data capture and documentation across the industry could be a way of handling that. I'm curious, Neil, your thoughts on from the lens of an EHR vendor, how you think about learning from the experiences of others and incorporating what that might be.
Yeah, absolutely. There's, on the one hand, the information in the EHR is incredibly rich. The detail about every patient's journey is incredibly broad and deep. On the other hand, so much of that detail is entered into the EHR as unstructured data and requires humans, sometimes assisted by machines, but it requires humans at the end of the day to help structure the unstructured data in certain situations. Those humans are involved in developing algorithms, interpreting the output of algorithms, but you can't take people out of the equation. And so, one area for improvement would be if upstream data entry included more structured data of critical importance to downstream uses, whether it's clinical care, whether it's research, whether it's quality improvement. I mentioned the importance of interoperability, which I think is preaching to the choir, but it's not only interoperability, the ability to get information out, but also the adoption of data standards that are common across users, so that the data from different sources can be used to answer similar questions, whether it be benchmarking for quality or whether it be a research question. So we have a ways to go before, in the way in which when I take my iPhone overseas, I have confidence I'll be able to charge it wherever I am. We're not yet there with EHRs.
I will have one follow-up question for you, Neil. You mentioned the concern over missing data in this same theme to be able to really enable research and decrease its bias. Do you have any suggestions on ways to address the missing data problem?
Yeah, sure. Keeps me up at night.
I was just giving you that.
I'd offer a couple of thoughts. One is the importance of conducting sensitivity analyses in terms of understanding not only the nature of the missingness. Is the missingness at random, or is the missingness not at random? If it is not at random, then perhaps it doesn't matter. If it is at random, perhaps it doesn't matter as much as if it's not at random. So there are analytic approaches that should be undertaken whenever there's a high degree of missingness to try and understand it. And then the other approach that we're taking is saying, hey, where there's missingness in key variables that are important to the question at hand, how can you reduce missingness? And one of the ways is by prospectively, intentionally collecting data for particular parameters. So if it is absolutely essential to capture detailed adverse event information, well, then collect that intentionally while passively collecting everything else that's routinely documented. If it's really important to have CAT scans done every 8 to 10 weeks rather than how it's done in routine practice, which might be 8 to 24 weeks across a population, will then specify and intentionally collect the outcome measure at pre-specified time points. So that requires prospective evidence generation, but you can, we're thinking about it as built upon a platform of routinely collected data, routinely collected real-world data, with the addition of intentionally collected data where it really matters to the research question at hand.
That was a fabulous way for us to end our session this morning. There's been a number of other questions in the public chat, and I'll encourage our speakers to take a look at those and perhaps put in an answer in writing in response to people's comments. But we will wrap up this session, and I want to again thank all of the speakers in this session for their participation and their thoughtful comments this morning, and a great kickoff to the rest of this meeting. I can't wait to transition to our next session.